And thank you everyone for attending this evening. It should be pretty informative, and we'll try to keep it light but informative at the same time. So no financial disclosures related to this presentation. I will be discussing some brand names, but these are mostly going to be mentioned because they're probably just more familiar to the folks in the audience. I don't have any endorsements from any of these companies. So kind of three topics that are very common in our practice and that any of the urologists in the office will see probably at least multiple times per day in an office setting. We'll talk about recommendations and guidelines for prostate cancer screening. We'll understand prostate enlargement and its potential impacts on health. And we'll also discuss erectile dysfunction, and we'll highlight some of the treatment options that exist. So a lot of men sometimes are hesitant to seek medical care or get screened for a lot of conditions because they feel fine and they usually don't have a lot of symptoms, or they'll kind of defer symptoms that may not be so bad. But really the goal of health screening is to detect problems or diseases before folks have symptoms. And in general, men are just kind of bad about seeing doctors, and we recognize that. But early detection is key. We want to encourage lifestyle change. And then if we find something that can be fixed, we want to do surveillance on that or offer some type of treatment plan to help reverse or slow the negative effects of that particular condition. And the old adage here, an ounce of prevention being worth a pound of cure, really goes a long way. For prostate cancer specifically, probably from about 2022 until now, we've just tipped over from 1 in 9 men being diagnosed in their lifetime to about 1 in 8 men. And it is the most common non-skin cancer in men. It's the second most common reason for cancer-related death in the male population, and we're approaching nearly 300,000 new diagnoses being made per year. That's an estimate from the American Cancer Society. It's majority in men in their late 60s into early 70s with an average age of 67. And a majority of men do not have any symptoms when they are found to have prostate cancer, which is why screening exists. Now, the American Cancer Society recommends an informed decision be made with your doctor, and this could be with your primary doctor or seeking care from a urologist, that men at average risk who have at least a greater than 10-year life expectancy, which is an estimation in discussing with your doctor with your other health conditions, that we should start screening at about age 50. For folks at higher risk and those people with a first-degree relative who are diagnosed at a younger age, or African Americans, we want to start screening or have those discussions at about age 45. And then if you have more high-risk features than that, such as more than one first-degree relative, that would be any brothers or your father who had prostate cancer at an early age, we want to screen even earlier, about age 40. Now, the American Urological Association, which we go by a little more closely, updated their guidance in 2023. The whole crux of this is that shared decision-making is important. It's very important to be having these discussions with your doctor because there are some potential harms from screening, like over-treatment, if we do wind up finding, for example, a low-risk prostate cancer. But these discussions really should be happening about age 45 to 50 now. The age got a little bit younger than it did in past guidances. And then if you do have those increased risk features, again, African Americans, folks with a family history, or if there's any known genetic mutations, we want to screen earlier. And this is having that discussion to understand the benefits of possibly blood testing. So a brief anatomy lesson here. The prostate is a walnut-sized gland that sits between the bladder, which is a muscular balloon up here, and the urethra runs through it like a tunnel. So this is a cross-section picture here, but kind of outlining the prostate with the laser pointer here. And its function really is to contribute fluid and nutrients to the semen, and it contains the connection for the ejaculatory ducts for sperm. Some of the screening tools we may use to look for prostate cancer would be a simple blood test, which is called the PSA, prostate-specific antigen. Now, it's a little bit imperfect, mostly because the normal prostate tissue will make PSA, but as numbers get higher, the suspicion is raised for cancer. So there was a threshold value of 4 or below, which is considered normal, and as we approach that level or higher, we start to get a raised suspicion and think about additional testing. But most urologists will care more about the trends over time rather than a single value. Now, a digital rectal exam is another way that we can screen for prostate cancer. This is a physician using a gloved and lubricated finger to examine the prostate through the rectum. And we're looking for size, making sure things are equal on both sides. We're checking for what I would tell a patient is a lump or a bump, or technically called a nodule, or if there's any abnormal firmness. Now, the value of screening with a rectal exam has actually gone down a little bit, especially in the American Urological Guidance from last year. So if that's deterring people in the audience from seeking screening, understand that we don't do that as commonly anymore, but we have some other tools up our sleeve. Now, the MRI of the prostate can be done in certain patients where if the PSA is elevated or the exam with our finger is abnormal, this can help guide the need for a prostate biopsy before simply recommending a biopsy off the bat. We might look for lesions or considered suspicious areas that can be scored by a radiologist, and this information can be used to perform a targeted biopsy of that suspicious region. Now, MRI is limited in that it cannot be used if you have metal or certain devices such as a pacemaker or a defibrillator, for example. And then there's kind of hot on the press is liquid biopsies. Can we just send a patient for urine or blood-based testing that will help eliminate the need for a true biopsy that's more invasive? And can this tell us if a patient has an increased risk of cancer, or can we diagnose cancer through these methods? So these are some things called exosome DX. Another one that's kind of hot recently is called My Prostate Score, or MPS 2.0. These are things where generally they're urine-based tests to look for genetic mutations that might raise suspicion for detection of cancer. Right now, we should be using these if it's going to influence a decision for a biopsy. Typically, I would use these in my practice if a man is more hesitant and we've already gone through the blood testing and the MRI and they're a little bit hesitant about proceeding with a biopsy. This can help support going forward or potentially deferring a biopsy. Now, the diagnosis using a prostate biopsy is the only true way to detect prostate cancer. It's done either under local anesthesia. Much more commonly now in our practice, we're using sedation. And essentially, an ultrasound probe is used in the rectum that's pictured here. And our technique now is, it can be done two ways, but in our practice, we've exclusively switched over to what's called the transperineal technique, where historically the needle used to pass next to the ultrasound probe to access into the prostate, which we can see in the picture here. But that carried a risk or an increased risk of infection. Now what we do is we go in the skin area underneath the scrotum to access the prostate without passing the needle through the rectum, which contacts the stool. And this allows us to do a targeted biopsy with the potentially prior MRI that a patient may have had. Now, there are certain risks associated with a biopsy. It's common for men to have blood in the urine or blood in their semen. If the traditional or historical transrectal method is used, men might have blood in the stool because we are poking a needle through the wall of the rectum. A little bit of soreness down below is normal. Some men, if the prostate is larger, they can have a difficult time urinating from swelling from the biopsy itself. And then more rarely, men may experience fever, and there can be a risk for infection or sepsis, which is really as close to 0% as we can get when we use the newer technique, the transperineal technique. So that covers the screening portion. We will discuss prostate enlargement next, and just to refresh some of the anatomy here. In terms of prostate enlarging, remember I said that the urethra runs through the prostate like a tunnel. So if I were to show you a true kind of front of the body to back of the body cross-section, the prostate surrounds the urethra like a tunnel, where as it enlarges, it has the potential for the walls of the tunnel to kind of close in on that urethra, possibly constricting the flow of urine. And in general, there are nerves and blood vessels that are near the prostate that also help aid in erectile function too, which comes into play later in the presentation. So this is called BPH, or benign prostatic hyperplasia. Prostate enlargement is another common term, and it can cause a lot of various urine symptoms in men. We think about things like weakness of the stream, pushing to start, where you're standing over the toilet and having to wait several seconds to start up your flow. There can be what we call as intermittent flow, or a stop and go as you're going, some dribbling at the end of your stream. A lot of men may experience wakening at night more frequently to urinate, and retention of urine, which means that you're not fully emptying your bladder and you're hanging on to a little bit of urine after you have already gone to the bathroom. Now, these symptoms are influenced by a lot of things. There's lifestyle factors, and the general medical health can really impact a lot of these urine symptoms. Things that we take for granted, just general fluid habits. If we're drinking excessive amounts of water, I would say upwards of 60 to 80 ounces per day. There are men who come in and they say, hey, I drink a gallon a day. And they're a little bit puzzled when I tell them that if they reduce the amount they're taking and cut it by, I don't know, 25% or so, that their urine frequency and a lot of these symptoms may get better. It's also impacted by sugary or caffeinated beverages. That's important. So these are all questions that we would ask during an office visit or look into your chart, for example, with regard to your other health. Blood pressure medications, if folks are on diuretics or water pills, that's naturally going to increase the amount of urine produced and increase the urine frequency. Diabetes, depending on how well controlled it is, you can spill sugar into the urine, and that will draw water with it and increase the urine frequency or urgency. And then even some of the newer medications, a lot of these injectable agents, especially for diabetes that are out now, medications like Jardiance that some people may be on, they work by allowing the body to filter sugar out of the bloodstream, but that spills into the urine and can lead to an increased risk for some bothersome urine symptoms. Some other folks may have some leg swelling where when at nighttime, when you're reclined, all of that swelling in the tissues or fluid in the tissues will go back to the heart, filter through the kidneys, and you're going to increase your urine production. And then sleep apnea, men who may have sleep apnea may also carry an increased risk for waking at night to urinate, sometimes from the condition itself. If you're trying to catch your breath and you wake up and there's a feeling of needing to go to the bathroom in the background that you might not have otherwise felt. Now, prostate enlargement, a lot of men, they come in and they say, hey, my primary doctor sent me over and I just thought these symptoms were normal, so I've just been dealing with it for years. And it's important to know that the size of the prostate doesn't always correlate with the symptoms. There are men with just mild prostate enlargement who have a very high degree of bother, and men with prostates that are 3, 4, 5 times the size of normal, and they have really just are not very bothered. In the longer term, the prostate can become so large that it might cause a higher amount of urine retained. And a lot of men would notice this and feel this over time. It's not just going to be happening necessarily in the background without you feeling some type of symptom. That's more rare. And that can affect the kidneys or potentially not allow men to urinate at all, where a catheter would be required. So when we think about the enlargement of the prostate, we would have asked a lot of symptom questions in the office, and I'll go over this a little bit later in terms of what a typical office visit may look like if you come to see us. We can consider some over-the-counter or herbal supplements. There's a ton of them on the market. Most of them, it boils down to having this active ingredient, which is an herbal supplement called saw palmetto. You can look at things where they'll say super beta prostate or a lot of things with the word prostate health in them. Interestingly, this was not found to be beneficial necessarily in terms of objective measures. When we looked at symptom scores or the ability for men to empty their bladders, this was actually studied against placebo and was not found to have a distinct benefit. Although we do have many men who report a benefit and say that they do feel like it does help their urine symptoms. Overall, minimal side effects, so a decent amount of people do try these. Now, a little bit of a busier amount of information here, but these are the prescription medications that are more common that we might think about and that some of you may be on in the audience. Alpha blockers are a class of medications that have become a little more fine-tuned over the years. Historically, they were older generation and used for blood pressure control, and then they also realized that men were having a benefit in terms of helping them urinate being on these blood pressure medicines. Now, the newer generation ones, things like Flomax, Rapaflo, Uroxetrol, which some of you may be on or may have heard of, they work more specifically to relax the muscles where the bladder meets the prostate, but they still can carry a risk of blood pressure lowering potentially. So this is called orthostatic hypotension. I describe it as you're bending down at the sink to get something from under the sink, and when you get up from that position, you feel a little bit lightheaded potentially. Side effects happen in about 10% of patients. The others are stuffy nose, and then a strange side effect, which I always let men know is a possibility, is called retrograde ejaculation. It's odd in that when ejaculating, semen may go backwards into your bladder, so you may have a dry ejaculate, or actually one that just produces less fluid going forward. It's not harmful to your health, but it is a strange side effect and one that does bother certain men enough sometimes to have to stop the medication or try something else. Now, Cialis is a medicine that we'll talk about for erection health as well, but in its daily dose at the lowest amount works very similarly to the alpha blockers and is known to help improve urine symptoms. Sometimes men may get headache, they can have some flushing, joint or muscle pains are fairly common with these medications as well. And then one that's a little more of a marathon rather than a sprint in terms of its effectiveness is called finasteride or Proscar. It's been around for quite a while. In a lower dose, it's used to treat male pattern baldness, but they found that it did help urine symptoms. It actually reduces the prostate size by cutting off the local testosterone that feeds the prostate, but that effect in terms of reducing the prostate cancer cells can take quite a while to work, and we're talking 6 to 9 months. Now, the side effects of this, because it's affecting some level of testosterone function, can have a little more sexual side effects. So I usually reserve this for older men who may or may not care about that as much, or who have baseline potential issues with sexual side effects that they may not mind this particular issue as much. And they're not very common. Not everybody experiences them, but that is one, a little bit of a different side effect than the other medication. So it's not the first go-to. And then getting into the weeds for the surgical options is a little bit out of the scope of this presentation, but I'm going to throw up some information about what happens when we start to think about why we would project a man to go on to surgery or counsel them that they would need a surgery for enlarged prostate. Now, when we're thinking about a surgery, it's necessary to do a diagnostic cystoscopy. This is a test where we place a camera through the penis using a numbing and lubricating gel, and we're evaluating the internal shape and size of the prostate to better understand what procedures a man may be eligible for. Now, the hard and fast indications for surgery is if you're catheter dependent and you cannot urinate without needing a catheter in place. If you have formation of bladder stones, that's an indication that there's stagnant enough urine that we really should be doing some sort of procedure to widen the channel to let a man pee better so that urine retention is no longer there. Or some men decide, just based on failure of medication therapy over time, that a surgery option may be better. Most of these options are done under general anesthesia or some level of sedation, and many of them don't include any incisions on the body. It's done through a camera or a device through the penis, with the goal ultimately for all of them that I'll throw up the list in the next slide. You're trying to widen the channel that runs through the prostate. Remember that tunnel of the urethra? We want to make a nice wide channel there to reduce that obstructing tissue leading to the urine symptoms. Now, the surgical options are many, tried and true, and sort of the gold standard now, probably for almost the last 100 years, even a little bit more, is the TURP, TURP. Some men know it as a Roto-Rooter for maybe their brother or their fathers in the audience who might have had a similar procedure. It's gotten a little bit better since over the years, but it's still really the gold standard. It's an electrical loop to shave the prostate. We have laser therapies for the prostate, which is kind of vaporization, meaning that we kind of melt the prostate tissue away using certain laser technology. Enucleation is similar to the TURP, where we would sort of open the channel wider by using a laser to remove the obstructing tissue. A urolift does not remove any prostate tissue, but it utilizes permanent clips or an implant to hold open the walls of the tunnel. And then there are some water-based treatments that unfortunately we do not offer at Capitol Health, but we are aware of them and can make appropriate referrals if a man comes in specifically interested in those. Resume is sort of a steam-based therapy to help to melt the prostate tissue away. Aquablation is a therapy that you use under ultrasound guidance to kind of melt the prostate tissue away with a high-powered water jet. For very large glands, we can consider a simple prostate removal, which we can do with robotic or minimally invasive surgery. And then there are some techniques that are a little bit newer and not as commonly performed, but you can embolize the prostate, meaning we put some coils or gel into the arteries done by a radiologist to help cut off the blood supply of the prostate to some degree to let it shrink over time. And then there's something called temporary implanted devices, sort of these stents that hold open the walls of the prostate, and they get removed after just a day or two to allow the channel to remain open from the stenting procedure. Now, most of the effects of the surgical options are very similar. Now, the goal is to create that wider channel. This does require temporary use of a catheter going through the penis to drain the urine. It's very common for some of these to require a hospital admission, at least one night in the hospital. Some of them are done as an outpatient surgery. Very common to have blood in the urine. Most of them will carry a risk of long-term retrograde ejaculation that's not recoverable or reversible like the medication effect would be. And a lot of men do experience some level of irritation when they urinate. This is either a temporary burning, urgency, feeling like they have to rush to get to the bathroom, going more frequently. And in certain cases, if the prostate is so large, it actually will be masking an overactive bladder in the background that once the prostate kind of floodgates are open, so to speak, and the channel is wider, many men in that situation might experience some new baseline irritation with urgency and frequency, and we call that kind of an unmasking of the overactive bladder. So take-home points here, really you just want to be discussing any symptoms of concern with your doctor, and these are sensitive issues. So really, if you have concerns with talking about that with your primary doctor, definitely seek out a referral to a urologist. We're very friendly. We deal with this all the time. We have very comforting ways to talk with people privately about these sensitive issues. And for many men, the decision for treatment, at least in the early stages when they have urine symptoms that might not bother them that much, it all depends on how much the symptoms are impacting the quality of life. What we would always recommend is lifestyle change first. If I have a man that really has an excess fluid intake, I'm telling them to reduce that fluid or try to stop drinking fluid within 2 to 3 hours of going to sleep. And sometimes I'm telling men to go get a sleep study, for example, to look for sleep apnea. I always would rather treat a root cause than put a Band-Aid on it with a medication. But there are certainly men who, in a lot of cases, may benefit from medical therapy. And although there's many options that we presented here, and especially some of the surgical options can be overwhelming, a majority of men do respond well to either a single medication or some type of combination medical therapy. And a lot of them don't ever go on to needing surgery. All right, we'll take a brief pause for 1 second. And we will switch gears into erectile dysfunction. So kind of a broad definition, and a lot of things can fit underneath the title of erectile dysfunction. In general, it's experiencing a less firm erection, one that may not be sufficient for penetration or satisfactory sexual intercourse, and sometimes the inability to sustain an erection through to completion of orgasm or to completion of intercourse. And this can occur at any age. It's more common in older men, and probably about 50% of men over age 40 may experience this in their lifetime. And the reason it's more common in older men, different than women who go through menopause and there's a much quicker change in regard to their hormone levels, the testosterone sort of declines and really peaks when we're teenagers or into our early 20s, and then over our lifetime it just provides a slow decline. Also, older men are just more likely to have other chronic medical problems that may be a root cause for erectile dysfunction. So briefly here, you can see that vascular issues, and these are things like peripheral vascular disease, or if you have heart disease, diabetes also leads to some vascular issues. That really covers, a little more than 2/3 of the main physical causes for erectile dysfunction. Medication side effect is another big one too. And I'll go over that in this slide here. So we talk about organic causes and psychogenic or psychologic causes for erectile dysfunction. The organic causes are things like, what are your medical problems or your other medical history? Do you have heart or vascular disease? Do you have high blood pressure and take medications? High cholesterol, diabetes, smoking, all of these issues can lead to some type of vascular disease, where if you think about these things having an issue in your heart blood vessels or other small blood vessels of the body, the same thing can happen of the blood vessels of the penis. Drugs or alcohol can do it. Sleep apnea has some link that we don't fully understand with regard to erectile dysfunction as well. And there are some men who come to see me where they haven't seen a primary doctor, for example, in a number of years. And ED sometimes can be the first sign of heart disease. And I'm often referring people back to their primary care physician or sometimes sending them for a cardiology evaluation just to make sure. Some medications we think about, and we talked about one earlier, the finasteride, if a man is on that, may lead to some level of erection issue. Blood pressure medications, specifically beta blockers, the ones that end in OLOL. Metoprolol, for example, is a big one. Carvedilol is another one. These can have a distinct side effect of erectile dysfunction. And we try to tease that out during an office visit, for example. Perhaps you might have started a new blood pressure medication recently and you're, in your mid 50s, and all of a sudden this issue started happening and there's no other clear cause for it. It might be the culprit is the medication side effect. And then there are certain anti-anxiety, antidepressant medications that may also be leading to erectile dysfunction. Psychogenic cause is the other side of the coin. These are things like stress, anxiety, and more specifically performance anxiety related to sexual activity that can really, a man can get in their own head about those issues, and that can lead to a loss of erection as well, or inability to achieve one because of the stress of the performance anxiety itself. And then depression, PTSD, we might see in a certain veteran population. The best prevention really here is lifestyle change and staying healthy. I say anything that keeps your heart and lungs healthy should keep the blood vessels that go down to the penis healthy as well. But we do have a lot of treatment options available. And then, again, just being comfortable talking to your primary care doctor or seeking a urology consultation to discuss these issues more privately. And then having good support from your partner at home is also very important. Sometimes pressure from the partner can be playing a role for some of the psychological issues that go hand in hand with developing erectile dysfunction. So it's important to have the support and talk openly with your partner about some of the issues you're facing. So what we would do for you when you come into the office is, number one, just have a conversation with you. There is a validated questionnaire, kind of paper form that you would fill out with regard to erection strength and your confidence with getting an erection to give us kind of an objective measure of how severe the condition may be. But we're just going to better understand what the symptoms are and when they started and how we can best help you. We would consider doing things, some of which I mentioned earlier. Checking testosterone is one good option as well. It's not a part of standard, your yearly physical blood work. So often once you get to the specialist, we would consider checking that if that's a consideration for lowering of testosterone as being a potential cause. We may be sending you for a sleep evaluation. We might be sending you back to your primary care physician to get a general health physical, to get some blood work, looking at cholesterol issues, diabetes, if we're concerned for any cardiac issues or heart issues. Now, one thing that's frustrating, I think, for patients and doctors alike is that there's no distinct diagnostic test. There's really no imaging test. There's not any sort of test that I can send you for that says you have erectile dysfunction and this is exactly why. Now, some of that doesn't matter as much because even if we had a test that could do that, the treatment options and the pathway we would take doesn't really change for a man. Now, it's still frustrating to not understand exactly why this might be happening or how we might be able to best correct it. But the best recommendation we can give is talking to your doctor about the symptoms, seeing if there is a potentially correctable issue, such as in the testosterone, and then doing good cardiac physical activity, 30 minutes a day, 5 times a week, and something that gets your heart rate up, like swimming, running, cycling. Keeping your heart healthy should keep your blood vessels into other small areas of the body happy and healthy too. Now, the other aspect I like to remind men or describe to them is that any treatment option that is offered for erectile dysfunction is considered on demand. It's not a chronic condition that you take a pill for every day, like your blood pressure. These are all taken timed or associated in time with sexual activity to be able to provide an erection. So we get into the treatment options, which the slides here are intentionally going sort of from the most conservative or least invasive up to the more invasive or potentially even surgical options at the end. So I have the generic forms, which The first three are available in generic form now, and they're much more cost effective than they were a number of years ago. There's even coupon programs available to get these medications in a more cost effective fashion. So the traditional Viagra or Cialis are the two that we most commonly would go to. Levitra is a little bit older, not as good necessarily, but some men do get a good response to that. And then Stendra is brand name only right now. Quite expensive. Really, the only difference is it may work a little bit faster, but not necessarily does one of these provide a better erection than the other. It really depends on how a man responds. Generally, they're taken about 30 to 60 minutes before anticipated sexual activity. So it's understood that it's not allowing you to be as spontaneous necessarily, but this condition does require a little more careful planning. They have to come along with sexual stimulation, which I think is another important point. You're not just going to take the pill and achieve an erection. It has to have some type of stimulation. The goal of the pill is really just to help promote the blood flow to the penis, providing hopefully a firmer and more sustained erection. And some of these may be affected by food intake, specifically the Viagra, you really should be taking on an empty stomach. Side effects are pretty common. A lot of men do experience some headache and flushing sensation. There can be some upset stomach. Congestion is common. Sometimes men experience dizziness. And the commercials from many years ago used to say, if you take this with nitrates for chest pain, this can cause an unsafe drop in your blood pressure. And that is a real thing. So any man, number one, if their heart is otherwise not healthy enough for sexual activity, we're definitely asking their heart doctor to help us out, or at least give the blessing that they are safe to take these medications before we would consider prescribing them. And then things like nitroglycerin, if a man takes that for chest pain, or if a man is on certain blood pressure medication, isosorbide has a nitrate component in it, which urologist has to be diligent about being careful prescribing these medications. There are creative ways we can do it where you don't take them at the same time, but we do have to be quite careful. Now, some of these next few slides do have some graphics associated with them. So a sidestep from medications and something that can be used in addition to medication is a vacuum erection device. This is a hollow plastic cylinder, which comes along with either a hand pump or a battery pump that's typically pressure regulated, so you can't overdo it. And essentially the flaccid penis goes into the cylinder, the pump is applied and pressure is applied, and then it will draw blood into the penis and requires the use of a silicone type ring at the base of the penis to help maintain the erection. Now, it's not as natural as a normal erection because we're drawing blood into the veins of the penis, which is not the standard way that an erection is produced. And it can cause some bruising and pain because of that. Sometimes men get a little bit of a numbness effect or even some blood blisters because they're kind of having to hold this venous blood in the penis with this ring for a period of time. Some men really swear by this. I would say it's not the best, but something that's not too expensive that often can be found either at a surgical supply type pharmacy, or I tell people honestly just to kind of look online and find something. It's usually between about $50 or $100 that you can find something, and this is reusable. Urethral suppository is a little device where a pellet is placed into the tip of the penis. And it comes with its own little applicator where when you push that little trigger, you can see in the bottom picture here, a little pellet gets deposited, and that will locally kind of ooze medication into the tissue, gets absorbed by the erection tissue of the penis, promoting blood flow. Now, this is not as common anymore. I think some men did experience pain and burning associated with this, and it may or may not provide the best strength of erection. Upgrading from there, and again, we go stepwise here, and this is only if medications by mouth are not working, we would consider some of these other downstream options. But I did want to present everything in terms of what was available to men. So the cavernosa is the erection tissue of the penis here. This is sort of a cross-section of the penis. So the sides, there's two kind of barrels of the penis, I would consider it. We're injecting either at the 3 o'clock or 9 o'clock position with a medication that uses a very fine needle. If there's anyone who uses insulin in the audience, these needles are very, very small. You're talking like a 27 or a 29 or 31 gauge needle. You're injecting a very small amount of medication directly into the penis. And with stimulation in about 10 minutes to 15 minutes, it should provide a satisfactory erection. Now, this one does carry the more serious side effect of a prolonged erection, and it could potentially lower your blood pressure because we're injecting medication rather than you taking it by mouth. And sometimes men do report some pain from the injections or even some scarring developing in the injection sites, which is why we would suggest rotating side by side or rotating areas along the length of the penis to some degree to reduce the risk of scarring. But this one does carry a good amount of the ability to titrate upward, meaning we can start at a quite low dose, and there's a lot of room to go up from there because we want to be safe, number one, and not cause a prolonged erection, but also we have the ability to get to a decent dose to provide a satisfactory erection for a man. And then there are sort of end of the line, a penile implant or a surgical option. And this is called an inflatable penile prosthesis, the one that's in the picture here. These are medical devices. They're surgically implanted to provide on-demand erections. And there are a few different options, 3 options really. One is a malleable, or we call it a semi-rigid prosthesis. It's always sort of firm and it's kind of bent up or bent down when it's in use and not in use. But it is sort of always kind of rigid feeling. It's not as rigid as a natural erection and maybe not as desirable as some of these pump options where there's either a 2-piece or this one in the picture called a 3-piece where you have a pump component down in the scrotum. This balloon up here gets tucked under the fat of the lower abdomen, and then there are the areas that get into the erection tissue of the penis where when you squeeze the pump in the scrotum, when you're ready to achieve an erection, the fluid cycles from the balloon into these cylinders, they're called, and that will provide an erection essentially for as long of a period of time as you desire. It's a little more natural feeling, but still sometimes the glands, which is the head of the penis, can be a little bit softer, which is not as normal as a standard or natural erection. And those are some of the reasons why men may not desire this as much, but it is an option kind of end of the line if you've gone through a lot of those other treatments. Now, there can be some pain associated while it's healing. It can't really be used for several weeks after the surgery while everything is healing. And then there are certain mechanical issues that can happen. I mean, it's a foreign body implant, so there can be malfunction of some of these components. They're rated to last about 10 to 15 years, but sometimes they can malfunction earlier than that. Just sometimes they can auto-inflate if there's pressure applied to the scrotum, for example. It's not as common. And sometimes these components can get infected, which is quite rare, but it may require removal or replacement of the prosthetic. And one thing that's important is there's really no going back after you do this type of surgery. To put those cylinders into the penis, you have to dilate that tissue. So there's really no further natural erection response from there. A couple words of caution here, and this is important because I do have a lot more men more recently, especially within the last year or so, coming in asking for certain treatment options that they've read about, seen things on television, heard about on the radio. One of them is shockwave therapy. I would say fairly heavily marketed. One troubling part is the technology is not approved by the FDA, but these are even some devices that you can purchase online for a few or several $100s. And the difficult part is the urology guidelines still consider these investigational. And they don't yet endorse these treatments because we just don't know, number one, what are the long-term effects of these treatments, but also what is the exact treatment pathway? How many sessions should a man receive? What's the strength of the shock wave in terms of pressure being applied, number of shocks, time that's being applied to the penis? So we just don't have that information yet, although it is being studied. So I suspect within the next several years, this may come out as being more effective in certain men. And then there's things that you can also find about stem cell therapy. Platelet-rich plasma is sort of an injection that you can put into the penis that is supposed to restore blood vessels and rejuvenate blood vessels. A lot of it is sort of wonder treatments that just are not, they're kind of in the headlines, but they're not mainstream, nor are they endorsed by most urologists. So what will happen in a typical office visit? You would come in, this is a private space. You're seeing a urologist. We handle these issues day in and day out. We have very comfortable ways of talking to people about these issues, and it really is truly a judgment-free zone. You meet with our medical assistants who are very experienced in handling these sensitive issues as well. And you do not have to tell them, a lot of medical information necessarily, but they may ask you to provide a urine sample if it's a urine-based visit or a prostate-related visit. We even have this device in the office to help calculate a flow rate. It's a special funnel that you would urinate into for us to understand how fast you're urinating and how adequately you're emptying your bladder. There are these questionnaires that are sort of standard across the country or the world to help evaluate urine symptoms or sexual symptoms, erection health. And then there's something called a bladder scan that we might do. Again, if it's a urine-based visit, it's really just an ultrasound that we can use to see how much is left in an individual's bladder. We'll talk about your symptoms and you bring up any concerns with us. And then we'll go over the treatment options and come up with sort of a shared plan. And I always tell people that I want them to be in the driver's seat and I'm sort of in the passenger seat helping guide what the treatment plan should be, but I'm giving you the tools you need to make a good decision to come up with a plan together. So just before we get into questions from the audience, some of the common things that a man may ask me, and then I get asked fairly frequently in a visit when a man comes in for prostate health, is there anything that they can do to shrink the prostate or just prevent it from growing? Their doctor tells them that their prostate is large. Well, what did they do in their lifetime to cause this? And there really is no clear cause other than being a man, number one, and just living day-to-day life and getting a day older each day. There is no distinct diet that's recommended necessarily for prostate health. There's a little bit of loose data to support that a high fat or high dairy intake may correlate with an increased risk of prostate cancer, but there's never been any clear cause and effect to say that there's a certain diet that would prevent prostate cancer or cause it, the opposite as well. And same thing, there's no real dietary factors that we can use to shrink the prostate necessarily. Some men come in and ask about selenium and vitamin E supplementation. There's a lot of things online about lycopene being beneficial to prostate health. And I think in general, a lot of these have minimal side effects, but there's never really a proven benefit to having them be medically recommended to do some formal prevention. And then, this isn't a question, but just a comment. I'm nervous to talk to my doctor about an erection problem. I think it's just, we want to help you. There's really nothing else that we want out of the visit. And really being open with us does allow us to give you the best recommendations possible. So, try to let the nerves fly out the window, the door when you walk into that office visit and understand it is a judgment-free zone. And we handle these things very commonly. So I thank everybody for your attention, and I'll certainly take any questions. I think I got some in the chat as well, so I can answer those too.
Yes, and I can read them to you, Dr. Polotti, or if you'd like to read them, whatever's easiest for you.
Sure. So I will answer the couple that I see that I think I got direct message, or maybe we all see them, but somebody asked, all the diagnostic and surgical procedures for an enlarged prostate seem painful and make me cringe. Can you comment on the level of pain and what's done to alleviate pain? Sure. So yes, while the procedures are going on, a majority of them you're under general anesthesia for, so you're not aware, you're not feeling anything. Most of the irritation after comes from the catheter being in place, and that's kind of what annoys most men. Because there's no incisions necessarily, I would say that most men experience a degree of bother, maybe like a 3 to 4 out of 10. People who have baseline, lower thresholds for pain, I would say maybe a 5 or 6 out of 10. And that is mostly just the bother from the catheter. It's just, it's a burning sensation. They constantly feel like they need to pee but cannot. But a catheter is constantly draining the urine. It's not your typical kind of sharp or incisional type pain if you've had other surgeries. Now, to alleviate those symptoms, sometimes we give a bladder relaxing type medication. And then usually your general just Tylenol or ibuprofen over the counter would be sufficient. If needed, we can give narcotic pain medicine, but we like to avoid that because it doesn't work so well for enlarged prostate type procedures necessarily. So hopefully that answers that question. Somebody asked about bicycle seats if they affect the prostate. So that's an interesting thing to ask because activities that irritate the prostate, I didn't say this in the screening portion, but that includes sexual activity. The act of ejaculation can irritate the prostate and lead to false elevations in the PSA. I have had some men who come to see me who newly started up doing Peloton, for example, and they had some potentially non-infectious prostatitis, which is quite rare. But these are things that can happen just from the kind of focal, I would say, pressure from a bicycle seat. If you're not wearing padded bike shorts, for example, or the seat is not appropriately padded, these things can either falsely elevate a blood test or sometimes lead to some level of prostate irritation or inflammation. Most people who are chronic cyclers, it sort of settles out to a new baseline, but it's kind of the people that may dabble in it here and there, or I would say the newcomers that it can cause newer symptoms potentially. I'm sorry, chat box is small. I'm just looking to see if anything else. So somebody asked about Peyronie's disease, if Xiaflex can help erectile dysfunction. So Peyronie's disease, I didn't talk about here, a little bit out of the scope of the topics I was asked to discuss, but that's a condition where a curvature develops of the erection, may or may not be associated with erectile dysfunction, but sometimes they go hand in hand. It typically causes pain in the beginning in an acute phase, and then a curvature is developing, but then pain generally would resolve after maybe 12 to 18 months, and then the curvature settles out at a new baseline. And again, it may or may not cause an issue with achieving an erection. So this question was, would Xiaflex help erectile dysfunction? Xiaflex is a medication that's an injection into a scarred area that's causing the curvature. That is a medicine purely used to reduce the curvature, not to improve the strength of your erection. So if you have an erection problem with a curvature, the Xiaflex will not help that. You have to kind of go through the same treatment options I discussed for erectile dysfunction, or there are certain surgeries you can offer. But some men who have severe curvature and significant enough erectile dysfunction, really sometimes the treatment is just jumping to a penile implant for those men. Somebody asked about the Exosome DX or ExoDX prostate test. Is it covered by insurance? Similar to PHI, which is prostate health index. So it's a newer test. I would say the way things work when new tests come out in the insurance world, which really bothers doctors, is usually Medicare is one of the first people to pick things up and start approving, and then the private insurance companies will follow suit from there. So, these companies, they want to get their test out there. They want people to use it. Right now, I'm very selective when I use it, mostly because I'm concerned that it may not be covered, and especially these, it's not whole panel genetic testing, but some of these things can become expensive. If people get big bills associated with this, the companies are pretty good about reducing it down to a pretty nominal fee if it was sort of a surprise bill. But we have done a few patients that it was covered by their insurance, yes. Prostate health index is another type of kind of adjunct for screening. I don't use that commonly anymore. I think it's going to be replaced by some of these kind of liquid biopsy tests, but more so, I just think, although it's a lot to undergo an MRI, that provides such great data rather than the prostate health index to help support the need for a biopsy nowadays.
Dr. Polotti, I received a message as well.
Yes.
When would you treat syndrome of hypogonadism? Any age considerations regarding testosterone replacement?
Yeah, so I mean, we never treat just a number. We always want to be reversing some type of symptom. So if we do testing and we do reveal that a man has hypogonadism, which is usually the fact that the testicles have just stopped making enough testosterone, where the signals from the brain may be sort of high, trying to make the testicles do more work, or just normal and it's just kind of burnt out based on age. So we go by the symptoms. If a man is experiencing fatigue, there's decreased energy, there's weight gain, there may be some difficulty in maintaining muscle mass when you go to the gym. And in those men, that's when we really focus on treatment. Insurance companies are a little bit tight in approving testosterone replacement. And actually, we've had a lot of trouble with availability of certain formulations. It's given either in a gel or a injection into a muscle. It is a controlled substance, which is why I think it's pretty heavily regulated by the insurance companies. So we don't take prescribing it lightly. We would certainly want a man to have certain symptoms, not just to be raising a number back to normal. But insurances typically require 2 separate testosterone values below a level of 300 to even be considered eligible for testosterone replacement. Plus, your doctor has to be documenting certain symptoms that are present too.
One other question, are certain people more at risk of prostate cancer?
Yes, so folks who have African American ancestry, or certain kind of Caribbean African or Afro-Caribbean ancestry as well, they're at definite increased risk just from a genetic perspective. Patients who have male family members, and we usually go by primary family member, so this is just one generation or the same generation. So your brothers, your father, or even if you're a little bit older and you had a son who had prostate cancer at a younger age, those all increase the risk. And then there are certain genetic mutations or genetic markers that may be positive, even in female family members. So young family members who are female who have certain ovarian or breast cancers, if you know, for example, that they have BRCA or BRCA mutations, there's a couple others that may be present in certain types of cancers. But women with breast and ovarian cancer, men at a much younger age with prostate cancers should be getting that type of genetic testing, mostly to help counsel family members to see if their risk would be increased.